have a special performance and also the photo session for all of you to join. And I would like to inform you, I don't want to take more time from you, and let me introduce the moderator today, Dr. Marlinda Adham. She is the former president of the Asian Society for Head and Neck Oncology. She is prominent professor in head and neck surgery from Indonesia, currently at the University of Indonesia, and she's among the founder of the groups. And so today she will take part as a moderator. So please welcome Dr. Marlinda Adham.
Thank you so much for the very nice introductions, Patra Foods. I'm happy to be here again with our second Asian webinar. And you will forget to announce that we have a network of the Asians Head and Neck network. So do you want to continue, Patra Food, because you also the initiators? So I will
Yes.
give it back to you.
Thank you. I was so excited that I missed the important message, and because we initiate this the webinar, we think that also we should do something together. Contributing to the field of the head and neck cancer, sharing knowledge and experience using the webinar or workshop that actually we have been doing for years for the conference and also the hands-on workshop for the head and neck surgery. So we would like to announce that we set up right now the ASEAN Head and Neck Network. We call it network. So it's kind of the cozy connection among the friends who have the same idea, same thoughts. And, we have a very special activities together. Besides the academic part, you will see at the end as a finale. So those of you who are involved in our first webinar have experience about this. So I think we have nothing more to say about this, but so excited to see how we grow in the future. So thank you to mention this, Marlinda. Give back to you.
Okay, thank you, Patrahood. So I'm happy now for our second webinar, and the first one we already have more people to more presenter and more there is a panel discussions. But nowadays we have two prominent speakers from our Asian region, which is Professor Alfredo Pontejos, and also Dr. It's quite difficult the name, yeah. So I will note Dr. Niyomudomwatana. So Dr. Noor is from the Rajaviti Hospital. So I would like to say a little bit because what is the special the second webinar is, because the second webinar is this coordinate and celebrating our World Head and Neck Cancer Day. What is the World Head and Neck Cancer Day? The World Head and Neck Cancer Day is originated by the IFNOS. The IFNOS declared on the 27th of July, and then when the World Congress in the New York on 27 July 2014. But what is the target? The World Head and Neck Cancer Days is there is a target in the advocacy for strengthening healthcare system and introduce community-based approach for the awareness. So this is a good actions because we are think about the how to share the awareness and also the enhanced expertise of physicians by upgrading their knowledge and skills through the program and conference seminar like this, because we are in the pandemic situations, but it doesn't matter. We have to just calm, stay home, but we can still hand by hand working together to propose or to elaborate all the awareness of the head and neck cancer, which is still a problem in our region, in the world. So I will not take a long time, but I will call the first speakers. The first speakers is I will tell you this Dr. Niyomudomwatana, MD, and he is working in the Rajaviti Hospital, and then followed by a clinical fellowship in head and neck surgery in the same hospital. And he is currently a full-time staff of the ENT department and at the Rajaviti Hospital. So Dr. Nut will talk about the title of his is the management of the oral cavity, oral cancer. So Dr. Nut, I will not take a lot of time, but please, the time is yours.
Thank you, Kapom. So it's being the great honor for me to let me share the experience about how I work about the oral cavity cancers. So in case that the attending have any question, you can ask me after the sessions. So I think for the oral cavity cancer it's a common problem for the head and neck field. So I think we have a lot of patients now. So we might start from the etiologies. I think everyone know that it's might related with the tobacco and the alcohol use. It can activate the gene mutations and the gene alterations, and that can cause cell deformities that and for the action of the tobacco and the alcohol itself can alter the other organ also, and that can cause the pre and post-operative complication also. And for the youngers, it might relate that with the HPV virus is one of the cause of the oral cavity cancers, and the other is about the bitterness, but anyway it's less common right now because of the unavailabilities of the bitterness consumes, and that can cause the oral chronic irritation, and that can cause the oral submucosal fibrosis. And the other cause may be the UVs and pipe smokers, and the other, and I think for the other non-smoker cause is also with about the dental processes after the dental restoration can cause the chronic irritation. It's quite common. And the pathologies can cause can start from the pre-malignant lesions such as the leukoplakias or erythroplakias or the verrucous hyperplasia. I think everyone are quite common. The treatment should be just only simple exercise and observe. And the most common for the head and neck cancer is squamous cell carcinoma and its variants. So I think I will skip the various type of the squamous cell carcinoma. I think you can read it after that. The treatment should be nearly the same or a little bit different. And the other cause should be the minor salivary gland cancer and the rare and less common is about the various type of the sarcomas. And the prognosis is, I mean, in the overall prognosis is depend on the degree of the invasion, include the peripheral resected margins, and the deep invasion is also play the major role of the prognosis, which can cause the regional metastasis, which can reduce the survival of the patients. So in general, we do the preoperative screening for more than the physical examination by the eye examinations and hand palpations. In general, we do that's all for the clinical evaluations. But anyway, in case that we expect that the bone invasion, we will send the patient for the CT scan to demonstrate the bone invasions. In general, for my experience, we just do the neck palpation of the lymph node metastasis without any clinical from the CT scan, and DMI also not necessary for all the patients, or even or in some patients I might send the routine panoramic imaging to demonstrate the bone invasions. But anyway, for the patient who have the regional metastasis, I mean, especially for the lower neck area, I may need to do the aggressive investigation for the distant metastasis. Sometimes I might send the patient to do the PET-CT scan if indicated. So when you have the information about the site of the primary tumors and the extension, I mean the staging and the surrounding soft tissue invasion, I mean you might have the ideas of the area that you will do the resections. The staging, I mean the cervical metastasis, I mean how extent of the lymph node metastasis, with what structure that you may need to resect. You will get the ideas about the defect site and the areas of the neck, which is quite important for the reconstruction planning. So after that, you might need to get information about the patient factor also, because as I mentioned that some of the patient is related with the alcohols and the tobacco use, which can cause the more underlying disease than usual. So it might relate it with the preoperative, intraoperative, or the postoperative complication also. And the most important, the quite important thing about the patient profile is quite important, because the choice of reconstructions might various, depends on the patient's profiles. In case that the patient is young and may need to use the complex reconstruction, the complex reconstruction might be indicated. So when you get more information, when you get information from the patient profiles and the disease factor, you can plan the treatment, and such as surgeries, or mainly it's a radio and chemotherapies for the oral cavity cancer. So this slide I show to nearly all of my presentations. So at first we might think about the step-ladder reconstruction. We might think about the more simplest one to the more complexities reconstruction, such as free-form reconstructions. But anyway, for my experience right now, so for the acceptable patient for the complex reconstructions, I might choose the more complex reconstruction first, such as in the younger male with the social active patient, the free-flap reconstruction might be the reconstruction of choice. So I might start with the first with the first first subtype of the oral cavities, which is lips. Mainly primary lesion of the site is to be the lower lips. Mainly happen with the men with their sun exposed histories, and the history of tobacco use. In general, the patient might present with the ulcerative lesion, but anyway, as I told you, you might palpate the lesion also, because in some case the lesion will grow submucosally, so it's quite important to do the palpation. And for the adverse prognosis feature is about the perineal invasion, bone invasion, and the upper lips or the commissure involvement or the regional metastasis, because of the risk of the regional metastasis to the parotid areas. The treatment option should be the surgery or the radiotherapies for the small lesion. But anyway, in general, if the patient doesn't have any contraindication for the surgery, the surgical excision should be the treatment of choice for the histological confirmations about the margins. And in general, I might preserve the radiation for the plan B. And in case that you do the resections, you have the defect. The area of the reconstruction of the defects depend on 3 factors. The most important thing is about the oral competence and the dynamic functions, and the cosmetic will be the last concern. I might go to the reconstruction step by step. If the defect is less than 1/3, to be, the total from 6 to 8 centimeter, you can do the primary closure. But anyway, if it's between 1/3 to 2/3, the local flaps, such as the caraplastic flap or abbase or S-lander flap, should be indicated. But anyway, if it's over than 2/3, the more complex reconstruction should be indicated. So this is the picture from my department. So we have the recurrence of the upper lip cancers. After the resection, the defect is not over than 2/3. So I might choose the regional flap, such as S-lander flap to reconstructions. We also have the larger areas of the defect. This is the recurrence of the lips cancer after the reconstructions and radiotherapies. The patient does not fit for the complex reconstructions, and you will see from the defect from here that the defect will include the buccal mucosa and the external skin of the cheek. So it's true and true defects. So we do not have much choice of the reconstruction. So we choose the forehead flap, which is less complex. But anyway, in general, we might not use this type of the flap quite much because of the unacceptable cosmetic, and the dynamic function of the oral cavity, of the lip is quite poor. But anyway, for this case is acceptable. So I might skip the neck treatment. So because Professor Alfredo will talk about that. And okay, crap. So I will go to the neck subside, which is alveolar ridge. The more common should be the lower alveolar ridge. The common presentation for the alveolar ridge cancer can be the oral erosion or the invasion, especially in the dental socket. You might exam quite clear to determine the oral socket invasions. So in general, the investigation that I mostly prefer for the gum cancer should be the panoramic views of the X-ray. It's quite cheap, and it will give us more details. But except in the symphysis and the parasymphysis area, which is I will send the patient to do the occlusal wheels. Sometimes the CT scan should be indicated if you want to exam in the neck area also, or the deep cortical invasions. If you have an evidence of the mandibular invasions, so just beware of the alveolar nerve involvement, because the margin that you need to do the resection should be more than the CT scan demonstrated. You might have more margin. For the lesion that involve the gum, but anyway, it's not invade in the periosteum, you can do the subperiosteal resection with the primary closure. I mean, you can undermine and advance the mucosas from the floor of the mouth and the buccal mucosas and do it primary closures. But anyway, if it is a periosteal invasion, you might do the marginal mandibulectomy, which can be rim or coronal resections. But anyway, if it's gross invasion for the anterior defect, you don't have another choice. You just have only do the bone flap, because if you leave it or you do not reconstruct, the patient might have the antigum, which is have the morbid for the patient. But anyway, for the lateral, you can do the soft tissue reconstructions, which are with acceptable functional loss. But anyway, let it be the last options. So I think I take a lot of time. I might skip some of my picture, my case. So this is the case that I do the marginal mandibulectomies, and I reconstruct with the nasolabial flaps. And this is the case that the tumor invade the symphysis area, so we don't have another choice. We might do the fibrillar reconstructions. Okay, and let's go to the other areas, to the oral tongue. Mainly areas the involved should be the posterolateral of the tongue, and when you do the examination by palpation, you might also observe the sensation and the deviation and the fasciculation or the atrophy of the tongue also, because it can demonstrate the deep invasion to the nerve. For the resections, you can do it transorally in case that if the lesion is quite small. But anyway, if the lesion is advanced, you can do pull-through technique or excision via the mandibulotomies. My personal favorite is pull-through. I always do the pull-through technique because I don't want to do the mandibular work after the reconstruction. But anyway, it depends on the surgeon preference. So in general, if the patient have the defect less than 1/3, you can let the patient do the secondary intentions. And if the tumor is involved the floor of the mouth, you can do the reconstruction with the skin graft. But anyway, if it's more than 1/2, you may need to use the radial forearm free flaps. But anyway, if it's total, you might use the high volume of the flaps, such as ALT. This is an example of the case of the lateral tongue cancer that involved the floor of the mouth. This is the thing that my boss do. I mean, Dr. Pakti, he did the mandibulotomies and the resection, and we set the flap with the radial forearm free flap, and after that we do the plate reconstruction. So once again, I will skip the treatment of the neck areas. The floor of the mouth, I think, is quite similar to the tongue lesions. So the choice of the reconstruction should be immediate reconstruction, because in general, if you do the resection, it might connect it to the neck area. So the reconstruction should be the watertight and preserve the tongue mobilities. In general, if the lesion is not involve the tongue or the lower gum, I might prefer to use the local, the locals and regional flaps. This is this example of the case of the floor of the mouth cancer that not involve the mandibles. I do the wide excisions of the lesion and the marginal mandibulectomies, and I use the submental flaps because it's quite thin and do not interfere the movement of the tongue. This is another case of the floor of the mouth. The same defect as the first case. But anyway, for this case, I use the platysmal flap to reconstruct. Let's go to the last subsite, the bronchial mucosa. In Thailand, it's still common that the aging patient will have the verrucous carcinoma, which is related with the betel nut use. And in general, we will do with the wide excisions and maybe include the marginal mandibulectomies for the proper adequate resection margin. You might also need to observe the muscle of mastication that indicated the deep invasions of the primary tumors. And the other thing that you might concern is about the obstructive silentinitis, which can cause from the tumor close or obstruct the opening of the parotid duct. For the small lesion, you can do the transoral resection with the primary closure, or in case that the lesion is quite limited, you can do the secondary intentions. But anyway, in the large, you can do you have a choice. between the transoral or pull-through or lip split with the flap reconstructions. For the larger lesion, I recommend you to do the through and through resections if indicated. So this is an example of the buccal mucosa cancer that invade through the external skin of cheek. We do the through and through resections and reconstruction with the ALT. And you can also split the flaps and reconstruct intraorally or and external skin of cheek. Thank you ครับผม
For the very informative presentations, and then there's a lot of things that we can have from your presentation. So I forgot to tell you in the beginning, before that, with the presentations, that we have a pooling of questions. And then we already, the presenters and the committee is already prepared 3 questions, and then the GNG will share the questions, and then the audience can give the answer by a click in your top or from your laptop or from your handphone. So can we start with the polling, Patrabut? Pimsuk? Pimsuk?
The poll has been launched to the participant.
So this is the first questions. A 55 years old female present to you with a 1.5 times 1.5 times 0.5 lesions at the lateral tongue. No palpable neck node. How would you manage the management? Wide excisions with neck dissection 1 to 3, chemo, brachy, wide excision, and sentinel node biopsy. Please give a vote. The host and panelists cannot vote. So done already for the first questions. Can we go to the second questions? Pimsuk?
Yes.
Yeah. So hopefully that the audience is already give a vote, yeah, for the first questions. Do not think a lot of time because we still have a nice thing to do. Enjoying the second presenter. Okay, the second question is 44 years old women come to the hospital with a squamous cell carcinoma of the lateral tongue, 4 centimeter extent to floor of mouth with palpable lymph node at area 3 centimeter. What is the most proper reconstructions of choice? Can you give the answer? Hello, Pimsuk.
Yes.
ช่วยเลื่อนให้โชว์ช้อยข้อ2หน่อยครับ
Can you give the what is the most proper reconstructions of choice? Yeah, Pimsuk.
Professor Marlinda, I think you can scroll yourself, and I think the audience can do it by themselves.
Okay. The primary closure, skin graft, platysmal flap, pectoralis major, myocutaneous flap, and radial forearm free flap. So just give your vote. Done? Done? Okay, I think it's already done. You don't have to take a lot of time. We still have more interesting things. The third question. 77 years old man with squamous cell carcinoma of the lower gum, 2 centimeters, clinical invade to the mandible without any palpable lymph node. He has underlying distant metastasis with complications of diabetic foot. What is the most proper? Nasolabial flap, pectoralis major myocutaneous flap, forehead flap, fibular free flap, or scapular free flap. So give your answer and then click from your laptop or from your handphone, and then we will keep the answer. Okay. So we will stop with this pooling, and then we will continue with the second presenter, and I will give time to Professor Alfredo Pontejos. Professor Alfredo Pontejos is a prominent head and neck surgeon from the Philippines and also the Asians, and also he gave a lot of talk, and then he also developing and then held the key positions in various head and neck organizations like the President of Asian Society of Head and Neck Oncology, ASNO, and then also a member of International Review Board of the NCCN guideline. He's still working in the Philippine General Hospital, but also working in the medical
doctors.
Manila doctors. So, but the interesting is he have a very nice voice and like Frank Sinatra. So you will see and so you will hear his voice. So keep in touch until the end of this webinar. So Professor Alfredo Pontejos, your turn to give a presentations.
Thank you very much, Marlinda. So, okay. All right, can you see my slide?
Yes.
Okay, good. So I was tasked to give this lecture on the role of neck dissection in oral cavity carcinoma. Nodal metastasis at the time of presentation is the most important prognostic factor. If the nodes are affected, the chance of cure is reduced by half. Curative surgery involves wide excision, as was mentioned by Nut, of the primary and/or neck dissection. Neck dissection, without a doubt, is warranted for T3, T4 lesions, even if you don't have nodes. But there is controversy in the treatment of clinically negative neck in early cancers of the oral cavity. I don't know if this was mentioned, but anyway, this is the 8th edition of the oral cavity cancer staging, and they have included depth of invasion. And so these are the added classifications, like if it's less than 5 millimeters depth of the invasion, it's T1. If it's greater than 5 millimeters, it is classified as T2, even if the lesion is less than 2 millimeters. And if it's greater than T2, less than 10 millimeters DOI, that's still T2. But if it's greater than 10, then it becomes T3. So basically, that's the difference now. Now, the rate of cervical metastasis, this is way back in 1996, but still holds true. T1 would have 18%, T2 33%, and so on. Now, the questions we'll try to answer is, how do we detect nodal metastasis? Is elective neck dissection needed for clinically negative neck node T1, T2 oral cavity cancer. Can watchful waiting be done for NO neck? What is the impact of tumor thickness in the risk of cervical lymph node metastasis? Is there a role for sentinel lymph node biopsy in detection of occult lymph node metastasis? And are there biomarkers that can act as predictors of occult lymph node metastasis? We'll try to answer them in this presentation. How do we detect nodal metastasis? This was mentioned earlier on by Nut also, but this is a study by Liao mentioning that the specificity would be high with CT scan, but the sensitivity is relatively low, okay, compared to MRI, ultrasound, and PET scan. Now, this is a comparison between clinical palpation, CT scan, and ultrasound. And you see that the sensitivity, specificity, and accuracy is high with ultrasound if ultrasound is done well, okay, compared to CT and, of course, palpation. And this is a systematic review by Hegab, and he noted that clinical examination is relatively low in terms of sensitivity, specificity, and accuracy. And he mentions that modern imaging like CT, MR, ultrasound, especially ultrasound-guided fine needle aspiration cytology, are more reliable than palpation. And of late, of course, we have the PET-CT, which can better detect occult neck metastasis than CT or MR imaging. And this can potentially impact the clinical management of oral cavity cancer patients. Is elective neck dissection needed for clinically neck node negative T1, T2 oral cavity cancer? Now, these are some of the studies, and you see here by Capote, Akhtar, and Mireya, Peng, and we had our own study, but of course, small number. And we noted that the overall presence of occult lymph node metastasis, well, in our study was 27.3, almost comparable with the rest, and in stage 1, 25, and stage 2, 27, comparable again to the rest of the studies. And this is by Capote. You see that occult lymph node metastasis was 26.8, and this was a comparison. Oh no, this is stage 1 and stage 2, 28 and 34 in the other study. Okay, LNAG 34%, and here 20%. So what is this? What this are all trying to say is that really even stage 1 lesions or T1 lesions have a significant nodal metastasis. Okay. So way back in 2002, in one of the American Academy lectures of Professor Eugene Myers, he said, treat all with selective neck dissection, because if you just treat patients with more than 15 to 30% risk, you have a lot of patients which could lead to poor prognosis. That was way back in 2002. Can watchful waiting be done for NO neck? So meaning you have a lesion in the tongue, you don't palpate for neck, so you just do a wide excision and then just observe the neck. Can this be done? A lot of studies have been done too, and these are some of the more prominent studies by Capote, Peng, Mireya, and Anil de Cruz, which had 500 cases. And you see the regional recurrence rate of elective neck dissection compared to that of watchful waiting was that elective neck dissection had significantly lesser regional recurrence rate compared to watchful waiting, which in Anil de Cruz study was 74%, meaning that a significant number of those patients where they just observed the neck had recurrences, more than 3/4. Of course, with Peng, it was similar, okay, but he's the only one that shows this. And then the 3 to 5 year disease-free survival, it's better if you have done an elective neck than if you did watchful waiting. And specific death rate was definitely lower if you did an elective neck dissection compared to that of watchful waiting. Okay, so these were the studies. Let me just run through this. Okay. There. So what these studies are just trying to say is that if you did an elective neck dissection on an NO neck, then you have better chance of survival, except the one with Peng. Now this is, again, the systematic review, and the Hegab mentions that the decision to observe or treat the neck is left to the patient and to the head and neck oncologist. In oral cavity cancer, clinically unknown necks, of which observation is appropriate, these are associated with T1, T2 lip carcinoma, T1, T2 oral tongue CA that has a less than 4 millimeter thick, and floor of the mouth cancer less than or equal to 1.5 in thickness. So what is the impact of tumor thickness in the risk of cervical lymph node metastasis? This was a slide presented by Shah in 2012, and he mentions that if the tumor thickness is less than 2 millimeters, you have 13% chance of lymph node metastasis, and you have a death rate of 3%. If it is between 2 to 9 millimeters, you have a 46% lymph node metastasis and a 17% death rate. Whereas if it's greater than 10 millimeter thickness, you have a 65% lymph node metastasis and a death rate of 35%. Now, this was compiled by one of my fellows, Warren Holgado, and he noted this as the risk of lymph node metastasis in relation to tumor thickness. And some have mentioned 5, 5.5, 4, 7, 3, 7. But see, majority pointed out 4. That's why the NCCN in 2016 chose 4 millimeters. So these are the studies again. Okay, just to expound on it. Okay, so here, if it's 7 millimeters, you have 57% risk of lymph node metastasis. Same is true with this one. Yeah, significant lymph node metastasis in greater than 4 millimeters. And this is the guideline of NCCN, which up to now is still being used in version 2, 2020, that for tumors with a depth greater than 4 millimeters, elective neck dissection should be strongly considered. Now, is there a role for sentinel lymph node biopsy in the detection of occult lymph node metastasis? So that is also a choice for T1, T2. You do surgery, you do resection, and you may do selective or sentinel lymph node biopsy. So these are some studies that showed that negative predictive values are very high, meaning if you have negative, the node is negative, then you have no nodes at all. You don't have occult metastasis. And the sensitivity is also good. So here, Sivantos 96%. Here, negative predictive value of 95% by Pedersen. And even for FLOP, it is a negative predictive value of 88%. Okay. So sentinel node biopsy, when performing it, you need to have harvest three of the hottest SLN. The only thing is, if you are going to do that, then the meaningfulness of SLN becomes questionable. So NCCN has mentioned this as its advantage. It is an alternative to elective neck dissection for identifying occult cervical metastasis in early T1s, T2s, oral cavity cancer in centers where expertise of this procedure is available. Advantage includes reduced morbidity, improved cosmetic outcome, and the rates of detection, as we have mentioned, is 95%. Now, the disadvantage is it is technically demanding. A procedural success rate for sentinel node identification, as well as detecting of occult lymph node metastasis, depend on technical expertise and experience, and sufficient caution must be exercised in performing it as an alternative to elective neck dissection. So what about biomarkers? Are there biomarkers that can act as predictors of occult lymph node metastasis? So these are some of the biomarkers that we have found. Cyclin B1, SPARC, ecadherin, odoplanin, MMP7, activin A, and of late PEMT. And so you see cyclin B1, their overexpression was positively correlated with occult cervical lymph node metastasis. Same is true with SPARC and cadherin. Okay, downregulation of ecadherin expression significantly correlated with positive lymph node status. Podoplanin correlated significantly with SLN metastasis at 83% specificity. MMP expression was associated with presence of occult metastasis. And same is true with activin associated with occult lymph node metastasis. And of late, the PMT is reliably associated with nodal metastasis, PNI, and of high grade. In prospective validation, PMT biomarkers may aid in decision-making over to perform a neck dissection in NO-neck or for adjuvant therapy planning. So, to conclude, despite advances in imaging studies in detecting occult metastasis, much is still to be desired, though PET-CT has strong predictive value. That's why if you go to Taiwan, it's routine. All of their cases, oral cavity cases, have routine PET-CT. Elective neck dissection, specifically selective neck dissection, is recommended for T2 or stage 2 oral cavity malignancy given the high risk of occult metastasis. For stage 1 clinically NO oral cavity cancer, elective neck dissection is recommended for tumor thickness greater than 4 millimeters. And the role of sentinel node biopsy in detection of occult cervical lymph node metastasis is promising, but requires technical expertise and experience. Identification of biomarkers in predicting presence of cervical lymph node metastasis may have increased utility in the future. Now, this is just a very, very new study, hot off the press, so to speak, and they compared PET-CT guided neck dissection and elective neck dissection. And this is his result. Of course, the numbers are skewed, 66 patients and 16 with PET-CT, and only 16 underwent neck dissection there, as compared to Group B with 169 patients without PET-CT and underwent elective neck dissection. It's a little bit skewed, but the results are a little bit promising. Group A had 86% regional control rate, compared to Group B, which also had 87%. And the 5-year disease-specific survival is comparable. So they concluded, based on this study, although it's skewed, neck dissection can be safely avoided when PET-CT reveals no neck lymph node involvement. The criticism there is only 16 underwent PET-CT, rather neck dissection. They should have done all, whether it's PET positive or PET negative, and see if the others had also occult metastasis. So with that, this is the book which we were part of, myself and Dr. Daryl Ann Del Mundo, and this has been published already. So this is the basis for the lecture. And I'd like to acknowledge these people, my former fellows, Dr. Safra Licodini Holgado and Del Mundo, who have helped me out in this paper. And so this is Philippine General Hospital. And thank you very much.
Thank you, Prof. Alfredo, for bringing the new things, and also you already write a book about the role of neck dissections in the oral cavity cancer, which is up until now, because we know that the occult metastasis in the oral cavity cancer is still high. So it's we need or not need to still give or doing the elective neck dissections or for the preventions. We are going to have like one, or we will see whether there is like a question from the audience, because we are happy that now the audience is around 316, if I'm not mistaken. Yeah, and then we are happy, but maybe it will get more participants until the end. So I would like to have a more maybe questions. Okay. Can we have like the polling again, and then we will discuss after the in the middle of the questions and answer. Is it okay? So can you give the again the after we hear the two well-known presenter, head and neck surgeon from Asian region. So I would like to again the second one after and before and after the presentations, and we will have a polling, and then we will discuss in the questions and answer part. So can we have? Yes. Okay, so I hope that after hearing the concentrations to hear the two presentations, so we would like to again give your votes to the three questions. Okay, 55 years old female presents to you is 1.5, 1.5, 0.5 lesions at the lateral tongue, no palpable neck node. How would you manage these lesions or this disease? Wide excision with neck dissection 1 to 3, chemotherapy, brachytherapy, wide excision, and sentinel node biopsy. So give a vote and then just click on your laptop or your phone, and then we will go to the second one. A 44 years old woman come to the hospital with ACCA of lateral tongue 4 centimeter extend to floor of mouth with palpable lymph node area 1, 3 centimeter. What is the most proper reconstructions of choice? You can choose primary closure or skin graft or platysmal flap, even pectoralis major myocutaneous flap, or radial forearm free flap. Give your vote. I'm counting until 1, 2, 3. Go to the number 3. 77 years old man, higher age, with a SCCA lower gum, 2 centimeters, clinical, invade to the mandible without any palpable lymph node. He has underlying distant metastasis with complications of diabetic foot. What is the most proper? Nasolabial flap, or you can choose pectoralis major myocutaneous flap, or even forehead flap, fibular free flap, or scapular free flap. Again, hosts and panelists cannot vote. We only give for the participants. We are happy to have more than 300 participants now. So we will keep those until we will have a question and answer. Okay, there is a lot of question here for Professor Alfredo and Dr. Noor, and it means that they are really hear your presentations. Okay, there is a, what is the skin incisions made for sentinel lymph node biopsy for oral cavity carcinoma? Is it by apron flap incisions? I think Professor Alfredo can answer these questions from Nadia Nasser.
Yes, thank you, Nadia, for the question. Normally, you have a scanner, okay, that checks for radioactivity. You inject a dye on the tumor, and then this should go to the node if there are nodes, and then the scanner will pick it up and it will light up, and you just make a small incision and remove the node. Okay, so it's just a small incision. The only disadvantage is if there are 3 of them that light up in separate areas, then you end up with 3 incisions. So although they're small, maybe they don't look as good as if you have done an elective neck. So that's one of the disadvantages actually. But that's what you do, just small incisions where you have the node that lights up. Thank you.
Thank you, Prof. Alfredo. So there is a question for Noor. Noor, how to test the flap of tongue is viable and reassure its location free of residual or chance of recurrence? After reconstructions of tongue, do all people need to have feeding tube and for how long? This is from Regina Talita Rosa. So now, Noor?
Actually, how many questions do I have to answer? So, okay, I think I can see.
Yes.
Okay, so it depends on the type of the flap that you set for the patient. But anyway, in general, if the flap is survived, the skin that line over the flap should be healthy. I mean, at first, the color of the flap should be pink, or is the same color as the surrounding area of the flaps. Yeah, that is the first routine examination that we do to observe the survival of the flaps. And the other thing that you might observe is about the I mean hardness. I mean the textures of the flap. The flap should be the consistency of the flap should be as normal before we harvest the flaps up, and the temperature is also observed. And I mean the other thing is about the capillaries refill. In general, I might compress the flap with the tongue blade and observe the capillary refill that demonstrate the normal vascularities of the flaps. But anyway, in case that we might need to do any interventions of the flap, such as we might, in case that I do the free flap reconstructions, I recommend the surgeon to do the skin picking every 2 to 3 hours to observe the bleeding, to make sure that capillary structure is the capillary function is still normal. So the second question is about the after resection, after reconstruction of tongue. Do all patients need in general, I place the feeding tube for every patient who do the tongue, the oral cavity procedure for at least 7 days or until the wound is healed. In case that there is some infection, the feeding tube should be prolonged, or in case that the wound is healed and and the patient cannot take the oral feeding them by themselves properly, I might recommend them to retain the feeding until he take the food proper and adequate. So it depends.
Okay, thank you, Nod. I will continue with there's a lot of questions, so I have to...
There's a question by Napadon.
Yeah, Napadon.
Yes.
Napadon. Yeah, you can answer, because I cannot...
In practical, what is the best method to evaluate tumor thickness correctly before surgery? That's a very good question. Normally, you can palpate. What Jatin Shah mentions, if your fingers almost touches each other, then probably it's less than 5 millimeters. Okay. In fact, there was a study comparing palpation and that of an MRI. And of course, MRI is a little bit more superior, but palpation doesn't lag behind. So I think palpation could be enough. Okay. And if ever you need imaging, then it's MRI. Okay. And there's another question here. Is there?
I think there's a question from Joya Brata Sarkar. What are the flap designs taken from neck for floor of mouth? Maybe first go to the note.
Okay, so I think it's okay. It depends on the degree of the resection that you want. But anyway, in general, we do apron for the oral cavities without any invasion of the skin or the lower face. ครับ
Yeah.
ครับ
Yeah.
Okay.
Cup. What's meaning of cup?
Yes.
So, Prof. Alfredo, there's this
question. Yeah.
Yeah. Once we found PET-CT showed negative occult metastasis, do we need to perform PET-CT regularly afterwards, or just based on clinical sign?
Yeah, that's a very good question, Regina. Of course, there are still a lot of studies. We must remember, we're not just talking of occult metastasis, but micrometastasis, okay? Yeah. So micrometastasis are not picked up by anything. So you do a PET-CT, it's negative for occult met. You just have to follow them up and maybe do a PET-CT maybe once a year, and then regularly check them up maybe every 3 to 4 months and do clinical examination. But of course, as you've seen in the presentation, watchful waiting, because this is close to watchful waiting, has a more deleterious effect than that of doing an elective neck. So normally I would discuss this with my patient, and if they're willing to undergo the elective neck, I would do that. If not, then I will just be following them up on a regular basis.
Yeah, Prof. Alfredo, and a note, I think that there is one question very nice, that in the setting of non-university hospital, preoperative tumor thickness evaluation is not simply small pieces of biopsy on tissue in oral cancer can be a good cancer of all entire tissue. Is there any non-invasive or clinically judged for tumor thickness before operations? This is non-university hospital, so we have to adopt also.
That's right. That's why I mentioned palpation. I can palpate. We're talking about T1s and T2s. T1 is less than 2 centimeters, okay? And then, so you try to palpate the thickness. Yes. So this is mainly for tongue, no? But for floor of mouth, that's difficult. Okay, so you need to do some MRI, or if you don't have an MRI, then maybe a CT with contrast might be okay. Yeah.
Yeah. Note, do you have additional information about this?
Well, I think for the ultrasound should give us the information about the tumor thickness also. So in my opinion, I think The ultrasound should be the investigation of choice, one of the investigation of choice. But anyway, and I think we can do it, I mean, ourselves, because my colleague also do it by himself also.
Yeah. Okay. I have a questions from our friends in the Netherlands, Geert and Gerritsens, to all panelists. Does the scientific committee have any experience with next generation sequencing to evaluate tumor behavior influencing prognosis? Maybe Prof. Alfredo or Dr. Noot?
Sorry.
No.
No.
No, not yet.
Not
yet.
this time. Not at
Yeah,
this
not
time.
Yet, not yet. Yeah.
Not at this time. Okay. Kirtan, we will wait until somebody doing some tests about this. Okay, thanks for
Marlinda, there is a question higher up. You're skipping a lot of questions.
Okay, I'm
Glenn Liamera.
Yeah.
Yeah, would chemotherapy, would chemoradiation help in T4 tumors, especially during COVID pandemic, if you cannot do long operations? That's a very good question.
Yes.
If it's T4, most of the time it's palliation, as long as you discuss with the patient that maybe it's not the best, but it still is palliation. So I think maybe you can offer it to them. Yeah, particularly now because maybe Thailand is better already, but Indonesia and Philippines, COVID still rampaging. So yeah, maybe that's just a very, 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 very valid question. Yeah.
So the chemo radiation is still the options for the
second option because you cannot operate.
Okay. So one question more, and then we will go for the discussions of the pooling.
Yeah.
Okay. What am I supposed to? No. Okay.
From Sahiruddin Zakaria. Yeah. How frequent do we need to do ultrasound for neck?
Yeah.
Follow up to look for recurrence. Yeah. For recurrence in the neck. Okay, that's a good question also. I think maybe every 6 months, I think would be okay. But of course, palpation first, and then you can do ultrasound for these patients. Yeah. If you are the ones doing it, it's good. It's a good advantage because you know what you're looking for. But if you ask someone else to do it for you, they might miss it. Yeah.
So what is your choose for the evaluations of the neck node? You do the ultrasound frequently every 6 months, or you do the CT scan?
It depends. In general, if we think that we do the physical examination adequately, so I think just do the neck palpations. But anyway, for the massive scarring or the local edemas from the surgery or radiation, I might send the patient for the ultrasound to evaluate the neck area.
Okay, so you are not doing a frequent CT scan every
not routinely.
Every 1 year.
No,
not routinely.
Not routinely.
Okay. Okay, so can you help me the JJ, can you show us before and after pulling, after the presentations, the pulling result, so we can discuss a little bit. So it makes okay. So the first questions, there is the answer is white excisions is 30%. White excision with neck dissection 45%, and the last one is brachytherapy. So, what do you think, Professor Alfredo? You raised
the majority is getting the feel of it, so it's white excision with neck dissection in this patient. Of course, you can do also sentinel node if you know how to do it. I mean, if you have the gadgets and you know how to do sentinel node biopsy. But definitely, if it's a 5 millimeters, we have a 5 millimeter then definitely wide excision alone is not the choice, right?
Yeah. So this is almost of the participants is giving the right answer,
Yeah,
isn't it?
yes.
Okay,
Majority,
so the second one is 44 years old women, and then with the 14 centimeters floor of mouth, and then the result they answer almost the same. PM flap with 36% and radial forearm free flap with 39%. No, can you give the information about what is the best thing?
So I think for this defect, you will see that we have the defects at least 6 to 7 centimeters. So it's quite. I think it's quite big. So I think you cannot do it primary closure or even skin graft. And for the platysmal flap, I mean I think it's not the reconstruction of choice because you see that you have the neck metastasis area. So in case that you preserve the facial artery in the area 1, so you have the risk of the let the tumors in the neck area also. For the reconstruction of choice, if the patient is man, you can do the pectoralis major flaps also. But anyway, this is young, middle-aged female. So we try to avoid their breasts to preserve their cosmetic. So the reconstruction of choice should be radial forearm free flaps.
Yeah, I think now the resource persons is already give the answers. So the third one is for the 77 years old man with the diabetic foot. What is the most proper reconstructions? There's like PM flap, the answer is 38%. And also there is a nasolabial flap. And then between those two, a node or Valfi, which one is more commonest that be used for this kind of patients?
Okay. So you see, let's see the patient profile. So we have the aging with major underlying disease. So in case that the patient have the diabetic foot, don't forget that the diabetes is a systemic disease. So in general, he might have the heart disease, so which is not suitable for the complex reconstruction, and the long surgery, long time of the surgery. So I do not recommend the free flap reconstruction for this kind of the patient. So and the forehead, and you will see that the defect size is just only 2 centimeters. In general, if you do the resections, you might have the when you do not reconstruct the bone, which is possible because the defect is occur on the lateral side. So the treatment, the flap that you need to reconstruction don't need to be a high volume or the large area of the flap reconstruction. So I think, so in my opinion, the nasolabial is enough. Or in some time, you can do it primary closure, because if you do not reconstruct the bone, you can do the area of the defect will be close together. So we don't need the large area of the flap. So I think for for the PMM, I think it's not. There is another thing that you might concern is about the neck area. So in general, we can skip the neck procedure for this patient because we cannot palpate we do not have the clinical positive for the neck area. We can treat the neck with the radiation or observe the neck also. So if you do not do the neck dissections, you cannot do the PMM flap reconstructions. So the major reconstruction of choice should be nasolabial flaps. Yes, Kap.
Yeah, thank you. I will continue, but there's one or two questions because they need the answer. In routine P16, P63 immunohistochemistry testing in tissue after resections is necessary in a case of non-smoking oral cancer patients. Maybe Prof. Alfie will answer this.
P16 and P63.
P16.
Yeah. In oral cavity, it's not yet proven. Oropharynx, yes. But so it can be done, but not routinely,
Yeah. Another is for both of you and all of us. What is the role of induction chemo in oral squamous cell carcinoma? Is that any role, or like just downgrading, or what? No. If you
we do not do the induction chemotherapies because we cannot predict the result and I think the complication of the treatment. The complication of the induction is quite unpredictable, and in case that is not respond, the patient may suffer and may have the complication of the surgery. So in general, if the patient can do the surgery, we might send the patient to do the surgery first.
Yeah, I agree.
Okay.
It's not
and
true.
you?
We don't do induction chemotherapy, particularly for oral cavity.
Yeah. So this is a question from me. How do you? No, it's real. Such as the patient's oral cavity cancer after the chemo radiations, how do you evaluate the response? There is a residual disease, or there is like a fibrotic by the PET-CT or MRI you would like to do? Prof. Alfie?
What is this? What is this?
The question is for the patients after chemo radiations, the big tumors.
Oh, okay. Post-op, yeah.
And how you evaluate the response? By the PET-CT is better or MRI? In your
good question. I think I would go. Of course, normally you wait for at least 3 months, 3 to 4 months before you start doing the procedures. Okay. Well, PET-CT would be good. Yeah. If the patient can afford it. Yeah. If not, yeah, an MRI. Yeah.
Not.
I think I also agree with Professor Alfredo in general. But anyway, we don't have much patient who have the induction chemotherapy before the surgery. But anyway, I think that the PET-CT should be indicated if the patient can afford.
Yeah. But don't forget that the PET-CT is also inflammation is also will give the light.
Yeah, but you wait for 3 to 4 months.
Yeah.
You don't just do this immediately. Yeah.
Okay. So I think, is there any questions that I have not really?
From Rajiv. From Rajiv.
Rajiv. There is a. Yeah, Rajiv?
Yeah. Well, in that first question, we just missed out that it was a squamous cell. Okay, so it was presumed it was squamous cell carcinoma. Yeah.
Okay, Rajiv, is his answer. So there is a question from Donyarat R. Donyarat. In the case of forehead flap reconstructions of lip, how to create a tunnel and move the flap to the defect? Note maybe.
So in general, we might rotate the forehead flap into the oral cavities that related with the zygomatic bone. In general, we can do it over or under zygomatic bone, and put it. In general, I will put it under the zygomatic bone to prevent the compression of the flap, and you just use the coker clamp to make a tunnel that wide enough for the insertion of the flap. Yes.
Okay. Okay. So hopefully it's answer already. Yeah, I just would like to call for the QR code for evaluation form from GJ. GJ, don't forget to the QR codes. So, Patravut, we already fulfill all the presentations with the famous head and neck surgeon from ASEAN, and then we already bring all the polling with the nice 3 questions, and also the questions and answers. So we will move into the next program. Patravut, do you want to just give a small remarks about the what we are going the next?
You don't have unmute Patravut.
Yeah, Patravut, you are unmute.
No sound. No sound.
No sound.
No sound yet. No sound.
ท่านหนึ่งไม่ได้ยินครับ
Patravut.
Hello.
Okay. Okay.
Yeah.
Okay.
Patravut, can you, or I will tell? Yeah, okay. Yeah, I think we already have a nice program, but as you know that the Asian Head and Neck network is like the shape of the people in the Asians that in the same patient, and we already started with the webinar, and we already start with the Asian Head and Neck dissection course, which is already 2 times, if I'm not mistaken. And then now we are also in the same patients with, we all like singing. So wait. Hello, hey. Okay, no, I would like to say that coordinate with the World Head and Neck Cancer Day, then here, where you are down and trouble and you need some love and care and nothing is going right. For the persons or the people having disease, then unfortunate conditions, remember that we are all together, hand by hand, we can raise, and then we can be together, and then we can be happy. So this is the song You've Got a Friends, and then singing by the Asian Head and Neck Network. And the composer, the pianist is Dr. Patravut, and also they have some persons from other countries, like Dr. Hon from Korea with the violin, and also Dr. Napadon from Bangkok, and there's some saxophone. So enjoy the song. Where's the song? Yes.
Will be there. You're down in trouble, and you need a helping hand, and nothing
much. Petrafood, do you want to give a closing for this very nice our second webinar of the Asians Head&Neck Network? Thank you very much for the very nice song that we are all happy. And then, yeah, we know that we like to singing, beside we like our scalpel. Petrafood? Unmute, you are unmute. Petrafood?
So, Professor Marlinda, I think Dr. Pratap would have a problem with the microphone. So I think I'm already talked to him, and he asked you to do the rest.
Okay, maybe I'm also, because I'm not alone as an initiator. I have Professor Alfredo, so I'm give a polite to Professor Alfredo to close these sections or give some closing remarks.
Okay, so we made this tonight because it's World Head&Neck Day, and this is our contribution to the World Head&Neck activity for this day. So I hope you enjoyed this presentation by Professor Nut and myself, and I hope you learned a lot from this from our presentations, and we hope to see you in the third Head&Neck course or session. So before we leave, we will have picture taking. So please stay behind for the picture taking. And thank you very much to all. We reached 320, I think, audience.
Almost 300.